Great. Well, thank you so much for this opportunity to share and present my research study titled The Association Between Discharge Time of Day and Discharge Outcome at an Academic Children's Hospital. I have about 12 to 13 minutes of presentation, and we can use the last 5 minutes for questions and discussion. So as Peter alluded, this is a study that I conducted during my fellowship in pediatric hospital medicine and my master's, which I did at Children's Hospital at Montefiore in New York City after completing my time at GEO. And it's good to see some familiar faces here. And I'm currently a hospitalist and assistant professor of pediatrics at Weill Cornell Medicine in New York City. I have no conflict of interest to disclose. As we all know, being a pediatrician and hospitalist, pediatric hospital discharge is a complex multi-step process. And during this process, our patients are often at risk for potential harm, either from suboptimal completion of discharge-related tasks or unnecessary delays in hospital discharge. From an operational standpoint, discharge before noon is often preferred to optimize hospital throughput. However, currently, very little is known about the optimal discharge time of day from Children's Hospital from a safety perspective. A few prior studies have examined the association between discharge time of day and discharge outcomes in pediatrics, but they often only included pediatric surgical patients or just a small subset of patient population, which limits generalizability. And this led us to investigate if discharge time of day is associated with 30-day hospital reutilization in all pediatric patients. And we hypothesized that pediatric patients discharged from hospital in the evening have non-inferior 30-day hospital reutilization rate compared to those discharged in the morning or in the afternoon. We believed that when children are medically ready to be discharged, evening discharge can be just as safe, even if operationally it may be less preferred. We conducted a single center retrospective cohort study at Children's Hospital at Montefiore, where I did my fellowship, which is an urban tertiary care academic children's hospital. We included patients under 18 years of age who were discharged between July 2016 and December 2019. And we excluded patients who were directly discharged from the PICU and ICU, transferred, left AMA, or died. And we also excluded patients who had an atypical length of stay, which we defined as under 12 hours or over 21 days. And we extracted data from the electronic health records. The primary outcome of the study was all-cause 30-day hospital reutilization, which was a composite outcome of emergency department visit and readmission. Discharge time of day was defined based on the time at which the patient left the hospital, which can be different from the discharge order time. We consider times of shift changes of nurses and physicians, and the operational definitions of morning discharge for the study was a discharge between 8 a.m. and 12:59 p.m. Afternoon was defined as between 1 p.m. to 5:59 p.m., and evening was defined as 6 p.m. to 10:59 p.m. Our primary analysis used a multivariable modified least squares regression to estimate the adjusted 30-day hospital reutilization. And in this model, we adjusted for known or suspected confounders, including demographic and clinical characteristics as listed on this slide. We did extract data on ethnicity, race, and preferred language, but did not include them in the final analysis because of a high proportion of missing data and limited data reliability. And the primary analysis was done at the level of each hospitalization. So this is the part that could get a little confusing with lots of statistics, but let's see. We used non-inferiority test to reject a null hypothesis that evening discharge is inferior to morning or afternoon discharge. And we did a power calculation a priori based on some assumptions and chose the non-inferior margin of 1.75% to get a power of at least 80%. This means that in order to declare non-inferiority of evening discharge, the adjusted rate differences of hospital reutilization between evening and morning and evening and afternoon, its upper bound of the two-sided 90% confidence interval, as indicated in this diagram, needs to be less than 1.75%. And this number will come back to us in the results section. So this flow chart illustrates how we use the inclusion and exclusion criteria to identify our cohort. Initially, 27,800 discharges met the inclusion criteria. And after using the exclusion criteria that I discussed earlier, there were almost 25,000 discharges from 17,317 unique patients. About a quarter of the discharges were in the morning, over a half in the afternoon, and about a fifth in the evening. Table 1 shows the demographic and clinical characteristics of my cohort, divide based on morning, afternoon, and evening discharge. The majority of the variables were significantly different between the three groups, partly because we had a large sample size. Just to highlight a few things, patients discharged in the morning tend to be younger, less complex, with fewer patients with complex chronic conditions or hospitalization in the past 90 days. There was no significant difference in the proportion of patients who had a PICU stay, and the length of stay was not significantly different. Table 2 shows the comparison of demographic and clinical characteristics between the index admission with and without hospital reutilization. Overall, there were 4,356 admissions that were followed by 30-day hospital reutilization. And similar to Table 1, many variables were significantly different between the two groups. The main takeaway from Table 2 is that patients who had 30-day hospital reutilization, they were more likely to have public insurance, chronic complex conditions, and hospitalization in the past 90 days. And the index admission also had a longer length of stay for those who did have 30-day hospital reutilization. This table shows my primary outcome. The unadjusted 30-day ED visit and readmission rate was the lowest in the morning, higher in the afternoon, and the highest in the evening. And the yellow row shows the unadjusted 30-day hospital reutilization rate, which is the composite outcome. You can see that it was 14% in the morning, 18% in the afternoon, and 19% in the evening. Using the regression model, adjusting for all the covariates discussed earlier, the adjusted rate of 30-day hospital reutilization was 6.2% in patients discharged in the morning, 9% in patients discharged in the afternoon, and 10.1% in patients discharged in the evening. And the last row here shows the adjusted rate difference using evening discharge as the reference. The most relevant values here are the upper bound of the confidence intervals, which needs to be smaller than the margin of 1.75% for us to declare non-inferiority. And in both comparisons between morning and evening and afternoon and evening, this value was above that margin. Therefore, we were unable to declare non-inferiority of evening discharge in terms of 30-day hospital reutilization. We performed multiple sensitivity analyses. First, we narrowed the outcome of interest from 30-day all-cause hospital reutilization to unplanned reutilization only. Some patients had multiple admission during the study period. So for the second analysis, we randomly selected one index discharge per patient to reduce confounding from non-independence. We also performed exploratory data analysis by limiting the outcome of interest from 30-day to 7-day hospital reutilization, changing the operational definitions of morning, afternoon, and even discharge. And lastly, we also used propensity score analysis. And the results were consistent across all sensitivity analyses. Limitations of our study include limited generalizability as a single center study. And this is an observational study, and there may be confounding by indication that we inadequately accounted for in our regression model. In addition, our outcome of hospital utilization is really only captured within healthcare network. So there would have been misclassification for patients who presented to ED or hospitalization to a non-affiliated hospital. However, we do not expect substantial bias coming from this because seeking care at non-affiliated facilities is expected to be independent of discharge time of day. And lastly, we acknowledge that hospital reutilization is only one aspect of health outcomes after hospital discharge. In conclusion, non-inferiority of evening discharge compared to morning or afternoon discharge with respect to 30-day hospital reutilization was not demonstrated. In fact, when we switched from non-inferiority test to superiority testing using 95% confidence interval, we found that morning discharge had a significantly lower adjusted 30-day hospital reutilization rate than evening discharge. One possible explanation for our finding is that there may be true barriers to high-quality discharges in the evening within our system, such as inadequate handoff, higher patient-to-provider ratio, lower access to discharge medications, or difficulty arranging follow-up appointments in the evening. Our conclusion is not necessarily that morning discharge is preferable from a safety perspective, but rather that there is a need to further explore potential barriers to high-quality discharges evening and to design and implement effective interventions. I would like to acknowledge the following individuals for their contribution to the study, and I'd be happy to answer any questions and open it up for discussions.
Great, thank you. That was an excellent presentation. I have lots of questions, but does anyone have any question? You want to put your hand up or just take yourself off mute to ask one?